Yeah, great. We gotta go. We gotta go.
Okay, we're going to get the horse back in the barn here. Our next speaker is Dr. Vlasa.
Okay,
He will be talking
nothing.
to us about general systemic personalized compounding.
So I'm Dr. Halesa. I'm the founder and author of Nitro Medicine, and I'd like to introduce you to my team of doctors who are adapting Nitro Medicine. And I think the problem that we have currently is that the insurance are not billing or not considering integrative and regenerative medicine as the mainstream, and that's why they are classifying it as investigational. And that's the reason they're not billing it, and that's the reason why doctors are having a hard time to practice integrative and regenerative, as we see it from all your questions about the financial aspect of it and the billing of it. And I think it has to do with many factors, and one of the factors is misrepresenting integrative and regenerative medicine, especially for doctors who are claiming that stem cells is causing a replacement, significant replacement effect, where it causes restoration of the cartilage when they're treating osteoarthritis, and that's a false claim. Or lack of understanding the chemistry behind integrative medicine, or misrepresenting it. And I think that's what Nitro Medicine is all about. It's about translating integrative and regenerative and functional alternative medicine into evidence-based medicine. Because if you see, the mainstream medicine was in one time alternative medicine, and then with using the evidence-based methodology, those alternative medicine turned to become a mainstream medicine. And so that's what Nitro Medicine is all about. It's about translating alternative, which include regenerative and integrative protocols, into evidence-based medicine. But the question is that, what is evidence-based medicine? Evidence-based medicine is an approach to medical practice intended to optimize decision-making by emphasizing the use of evidence from well-designed and well-conducted research. And so we have to have three things: publish it, randomized controlled trial with the same results, known mechanism of action and predictable side effects, and monitored by reliable, accurate, and objective diagnostic tests. If we use this methodology when we are creating the protocols for integrative and regenerative medicine, I believe the insurance will start billing for it, I believe the FDA will approve it, and I believe the doctors will start practicing it. And so, let's give an example. When we manage hypertension, right? So basically, we have many choices, many drugs that can manage hypertension, but it's really based on the patient condition, based on the doctor's clinical expertise, and also based on the best research evidence, these are the components of the evidence-based medicine. So let's say, for example, we have a patient with high blood pressure, and he has also heart failure, congestive heart failure. So what drug you think will be the best for managing hypertensive patients with congestive heart failure? I would use Lasix, right? Because it will help to get rid from the excess of the fluid of the congestive heart failure, and at the same time drop the blood pressure. But if we have a patient with hypertension and diabetes, what you will use? So it's all about patient condition, clinical expertise, basic research evidence. All these complete components will give us the answer here, right? So hypertension and diabetes, what will be the best? Captopril, because captopril does prevent the angiopathic damaging effect on the kidneys, right? All right, so if we have a patient with ischemic heart disease and hypertension, what would be the best drug? Beta blocker or carbidol, right? Slow down the heart, at the same time lower blood pressure. So here, the choice of the medication is based on three things, right? Based on the clinical expertise of the doctor, based on patient conditions, and also based on the best research outcome out there. Okay, now, in addition to that, when we are going to prescribe captopril for the patient, I think it's better if we know the patient will be tolerating the captopril in the beginning, right? And we can do that by using pharmacogenetics. So now we are choosing the right drug based on the genetic and the metabolism of the individual, and that will open the door for personalized medicine, right? Because not all the patients will be tolerating captopril. We know the side effects of captopril, it goes dry cough, right? And so if we do pharmacogenetics and we find out that this patient cannot metabolize captopril, then it's better for us to choose another drug instead of giving it to him, and then he will be eventually discontinue taking it. And we can move it to, or change it to angiotensin receptor blockers, for example, right? ARB, instead of giving captopril. So that is another, or opening a door for what we call a personalized medicine in choosing the right drug. And so, what is nitromedicine? Nitromedicine is a new medical specialty that focuses on developing diagnostic and therapeutic protocols to enhance stem cell therapies, manage oxidative stress-related disease by modulating nitroredox-sensitive epigenetics and biochemical pathways. So we find out that all those chronic diseases, whether it's chronic inflammatory disease, chronic infectious disease, degenerative disease, immunological disease, pain condition, cancer, psychological, metabolic disease, cardiovascular diseases, they are sharing a common thing, which is increase in the pathological free radicals, right? And decrease in nitroxide bioavailability. And if we are able to restore the nitroredox balance, we can slow the progression of these diseases. Whether this disease is affecting any organ of your body, the heart, the lung, so they are endless, and we call those conditions oxidative stress-related disease. And that's why when we say alpha-lipoic acid, for example, helps patients with hypertension, patients with diabetes, patients with Alzheimer's, people will ask how one supplement can help all these three conditions, right? It sounds for the mainstream doctors as a snake oil. But if we say all those three conditions are oxidative stress-related diseases, they have high pathological free radicals and low nitroxide bioavailability, and that the hypertension is caused by endothelial dysfunction, and endothelial dysfunction leads to decrease in nitroxide bioavailability, and nitroxide is very important for the blood vessel compliance, right? And it controls the blood pressure of the patient. So if we are giving alpha-lipoic acid, which helps to neutralize the free radicals, and directly increase the nitroxide bioavailability, this will improve the blood pressure of the patient and decrease the need of that too much of the big pharma hypertensive drugs. Also, alpha-lipoic acid helps patients with diabetes, type 2. And how? Because the diabetic resistant is caused by increasing the pathological free radicals and decreasing nitroxide bioavailability. Metformin is a drug that we are giving. How it works, metformin metabolizes in the liver and turns into nitroxide donor, and then nitroxide increases the sensitivity of the insulin. So if we give alpha-lipoic acid neutralizes the free radical and directly increases nitroxide bioavailability and increases sensitivity of insulin.
You know that Dr. Watson, the founder of DNA, actually takes metformin every day because he is certain that it prevents cancer, even though it's a diabetes drug.
I'm not saying metformin is a bad thing and discontinue it, but if we can do more of natural thing and reduce the amount of metformin, that would be great. And metformin does have side effects because it does increase the free radicals by interfering with the mitochondria.
Right, the risk of CVD just came out, papers just came out.
Right.
Vascular disease.
So that's the problem with using metformin and also using statin in chronic way it does interfere with the mitochondrial metabolism, and it causes increase in pathological free radicals and the side effects of statin, which is damaging the liver and the muscles, right? So, knowing that all of these conditions are oxidative stress-related disease, if we redefine this condition as oxidative stress-related disease, then we can have better understanding of how integrative and regenerative medicine work. Because the ultimate mechanism of integrative and regenerative and functional medicine is to restore the nitroredox balance. And we're going to see that in the coming slides. So, if we restore the nitroredox balance, we can slow the progression of oxidative stress-related disease, which are endless. Almost all the chronic diseases have some components of oxidative stress, right? So, how we manage oxidative stress-related disease, we use what we call the nitroredox modulator therapies. And I classify them into biologic, chemical, energy, and psychotherapy. Biological nitroredox modulator are stem cells, PRP, probiotics. If anybody want to add more, biological nitroredox modulator, stem cells, PRP, probiotics.
Ozone.
Ozone is chemical, anything biological. We can add amniotic fluid. Well, all those stem cells, regardless what they are sourced from, they are ultimate nitroredox modulator. They are rich of thiols and polyphenols and cytokines, redox enzymes, growth factors, right? So they contain the nitroredox chemicals. And so giving stem cells, living stem cells, or even dead stem cells, we can still get some, or get, you know, the effect of the stem cells, whether it's dead or living. We prefer it to be living because it have that exosomes activities active and ongoing. But the dead stem cells is not bad because they are rich of chemicals that help to restore the nitroredox balance. Chemical nitroredox modulators. Thiols, nitroxide donors, polyphenols, ozone, IGF-1, protease inhibitors, 6-hormone, antioxidant enzymes, cytokines, vitamin, and detoxification. Anybody want to add more to chemical nitroredox modulators? I think everything that's been discussed previously, all the things that they're using chemically can be put under chemical nitroredox modulators, including protease inhibitors. I'm very interested in protease inhibitors. It's something new and I'd like to add in the chemical nitroredox
What about phytonutrients in food?
What is that?
Like, you know, I mean, it's a no-brainer, but I don't see food or phytonutrients on there at all.
You're talking about the fibers for the constipation?
No, because, you know, our food contains the vitamins, but the vitamins is listed. You know what I'm saying? Like, I guess I don't understand your definition of, like, you know, not chemical, because I consider food to be about as natural as it gets. So the vitamins are up there as a separate...
Oh no, when I say chemicals versus biological, chemicals would be big pharma products or supplement, anything that's chemistry. That's, you know, made from chemical, because they're chemical atoms and molecules, right? We put in, whether it's nutraceutical or big pharma products, I put them as chemical versus biological, and versus energy nitroredox modulators, which are phototherapy, electrotherapy, electromagnetic therapy, cryotherapy, sonotherapy, exercise, acupuncture, physical therapy, low calorie intake, all of them, they do restore the nitroredox balance. And then we have psychotherapy, nitroredox modulator, cognitive therapy also helps to restore the nitroredox balance. People will say how the psychotherapy, cognitive therapy does that. We know that stress goes sympathetic overactivity goes secretion of norepinephrine stimulate NOx enzymes stimulate the production of free radicals. And that's how, if we're able to, by cognitive therapy and psychotherapy, able to calm the patient or lower the tone of the sympathetic tone, then we can restore the nitroredox balance. And I am working with some compounding pharmacies. We are developing formulations to manage all oxidative stress-related disease, listed here, whether it is for skin conditions or musculoskeletal, and I recommend the ingredients that would help to restore the nitroredox balance, which are the thiols and the polyphenols and nitroxide donors and many more. Okay, so It's very important that if you have any therapy or any protocol, in order for the FDA to approve those therapies or insurance to pay for it, you need to show that it's working. And so you have to have an objective diagnostic testing, not just saying, oh, the patient feels good after the stem cell injections or taking vitamin D. That's not enough. You have to have an objective evidence that your treatment works in restoring the nitrogen balance. So how we can, or what are the diagnostic testing? Well, inflammatory and oxidative stress markers will be a good one, right? NuNOW, which is coming from lipid peroxidations. Oxidized guanosine, which is coming from oxidized DNA. Those markers can be detected in the blood and the urine. Telomerase testing, right? Shortening of telomeres can be caused by oxidative stress. So if you have short telomere, that means the patient is in oxidative stress. If you are giving the treatment to restore the nitrogen balance, we expect that the telomerase testing will be improved, right? Okay, the other testing is ANS. Have you heard about ANS testing? Autonomic nervous system testing. Testing the sympathetic and parasympathetic tone. Anybody doing it, practicing it? Good. Because that will help to really monitor the efficacy of your integrative medicine. In fact, I consider this system, which is an ANS, pseudomotor anterior function test, as the diagnostic tool, a stethoscope for an integrative doctor. So if you don't have the ANS testing or the pseudomotor anterior function test, it's like a doctor without stethoscope. So this is how much very important to have. If you consider yourself an integrative medicine doctor, I would recommend you to start having this system in your clinic. Because when you give all this integrative medicine, let's say you give vitamin D, right? And you say vitamin D does help to increase the expression of antioxidants, genes, epigenetics, and it helps to increase the nitric oxide bioavailability and buffer the redox and decrease the inflammation, right? But really, if you want to know if it's working or not, then if you're able to improve the tone of the sympathetic before and after treatment of vitamin D, then yes, your system is working, or your treatment is working. If you're able to improve the endothelial function test, we know the endothelium that line the blood vessels are very sensitive to the free radicals. So when they are high, you will have abnormal endothelial function test. So when you're giving all this integrative medicine treatment, vitamin D, vitamin B12, polyphenols, those antioxidants, glycolic acid, and you're able to manage and restore the nitrogen balance, then you will see the improvement in the endothelial function test. So if you're looking for reliable objective diagnostic tests that help to monitor the effects of your integrative and regenerative medicine, use the ANS pseudomotor. Now, pseudomotor testing helps to monitor the efficacy of managing neuropathy, right? It has to do with the sweat gland dysfunction. We know the patients with diabetes, they have a problem with their degeneration of the sympathetic supply of the sweat glands, which is unmyelinated fibers. So unmyelinated fibers are very sensitive to the high free radicals. And if we find out that the sweat gland is not working, which how we find it is that they don't secrete, or they secrete what we call diluted sweat, right? And we have this conductive testing that will test the sweat itself. And if it's diluted, then that means your sweat gland is compromised. That means your sympathetic is being damaged. That sympathetic is unmyelinated fibers. And all unmyelinated fibers are sensitive to the high pathological free radicals, and that will include the C fibers. So it's indirectly measuring the damage of the C fibers of the neuropathy. So if you want to monitor the efficacy of your treatment of diabetic neuropathy, especially if you're using topical nitric compounding, which contain nitric oxide, polyphenols, and thiols, then use the pseudomotor testing before and after. And if you're improving in the sweat gland, that means you're improving your sympathetic, and that means you are improving your C fibers.
Well, a good side effect is they have less body odor.
What is that?
They have less body odor as a side effect of that because the sweat gland has no function.
Yeah. Right.
There's the silver lining.
Right. Yes. So, so I'm working with the Germans. They're more open-minded than the United States. They have this restriction on doctors in being creative. So I'm working with Dr. Weber, developing photosensitizers. What happened is that I use this photomedicine device, laser device, photomedicine, in the clinic that I used to practice in pain and regenerative medicine. But we go to the Amish people and we help them in managing their, in general, all their conditions, including cancers. So I use his photomedicine device, laser device, in managing cancer using photodynamic therapy. Everybody knows about photodynamic therapy, right? It's you inject the photosensitizers, and you activate them with light, they generate free radicals, and they kill the cancer. But he was using only visible light photosensitizers. And so visible light photosensitizers like E-chlorine, ethylene blue, the problem with them is that the laser does not have that much of penetration. So we're using red light, blue light, but doesn't have that much of penetration. And so I had a patient and she has metastases all over the body. And I tried using the visible light photosensitizer and photodynamic therapy. The problem is that when it's metastases all over the body, and you're trying to shine the light to activate those photosensitizers, those light does not penetrate that deep and does not get hit into the metastases, especially when it comes into the liver. So I start thinking or looking for infrared photosensitizers. Ultimately, I find something that's called ICG, indocyanine green. Have you heard about it? No? It's used for angiogram. It's a radio opaque. So it's FDA approved, clear. And also, it is infrared photosensitizer. That means it can sense the infrared, it activates by infrared, it generates free radicals, and kill the cancer. So we worked, me and Dr. Weber, developing what we call the PLGA, liposomal loaded ICG, because when you turn it into nanotech, or nano-delivered, you can get better concentration of these nanoparticles into the cancer cells. And so we are loading it, we loaded it first with liposomes, and then now we're doing PLGA polymers, and they are nanoparticle. And we have great results because now, when we inject them into the body, along with low-dose chemotherapy, not high dose, we don't use high dose, we use low-dose chemotherapy, and those chemotherapy, they are photosensitizers as well, like Doxil. And so Doxil, ICG, we put them inside the PLGA along with polyphenols, curcumin, and we inject them into the body, and then they concentrate into the cancer cells, and then we radiate them with infrared, which leads to activation, generation of free radicals, and kill the cancers. We are trying to improve our polymers of infrared photosensitizers, trying to add ligands that helps to target those cancer cells, and we are adding polyphenols for sure, and we are getting great results out of it. And you can visit us in Germany in our clinics there, and you can see all the results that we have. But also, we are using the ICG not just for treating cancer, but also for diagnosis. So how is diagnosis? I believe everybody knows about positron emission tomography, right? PET, right? And so how the PET works is there are sugar, they radiate positrons, inject into the body, they concentrate in the cancer cells, and then when they radiate positron, they hit the tissue, they turn to gamma radiation, and then you detect those gamma radiations. So that's why you can visualize those cancer cells. So we do the same thing with ICG. ICG polymers, they are loaded inside the cancers, and then we sensitize them with certain wavelengths, and then they reflect emission light that can be detected by cameras. And so in the future, we will have infrared emission tomography, and that's what we are developing in Germany. It will be more sensitive than even PT in detecting cancers.
Is this giving you more information in simple metabolic activity at your site? Because usually you look at PET, you know, you're looking at glucose uptake, you're looking at metabolic activity at the site.
Right.
It sounds like with this, you're getting more information than that.
Yes, so we're getting all those, the cancer cells, they will engulf those ICG, they will take them in
ICGs, yeah.
by endocytosis, and because of the ligand and because of the PLGA is positive, it's kind of negatively, relatively charged, and they attract to the cancer cells, so they will be taken in. And when we radiate them, we are destroying them. At the same time, we can see the emission light that can be measured and detected by certain cameras. We call them infrared cameras.
So can you quickly, last question, you can quickly then look at tumoricidal activity at both the primaries and in METs?
Yes.
Using this?
Yes. Yes. So that's, and it's going to be an infrared emission tomography system in the future. That's what I am right now in development process with the Germans. Okay. So, how much I have minutes? 5 minutes left?
10,
10?
if you want to kind of stay on track.
Right. So in stem cell therapy, I think because of all this regulation that we have, again, stem cell therapy right now, now they're turning it as a drugs,
Their guidelines.
and the guidelines are very tough. So I'm trying to make it simple for the doctors, for the patients, for the regulation here in the United States. I'm not talking about Germany and Mexico, which we have clinics affiliated there, but I'm talking about the United States. And I'm trying to make it easy for all of you guys. So in musculoskeletal conditions, do we need really the bone marrow stem cells, the fat stem cells, injecting into those osteoarthritic joints? No. The reason why is that, first of all, the stem cells that we are getting from the bone marrow and fat tissues, they are not going to build the cartilage, right? They will slow the degradation of the cartilage. Can we do that with just extracting healing components from the blood, as effective as doing it from the bone marrow and fat tissues? Yes. And so if we take 200 ml of blood, not the regular PRP where they take 50, right? You take 200 ml of blood, and then you put them in 50, 50, 50, and 60 syringe, but they are modified syringe that I am developing a kit that has a cup and has a removable cork, so that the syringe turn into a centrifuge tube and then back to a syringe, so you can get a complete closed system here, from extraction of the blood to injecting it back to the joints. And so you centrifuge this 50 ml, 4 of them into the centrifuge. How much? 1,000, 5 to 10 minutes. What will happen? Red blood cells will go in the bottom, right, deposit. And what's being left up is the plasma, the PRP, and the white blood cells. And then you open the cup and you release the red blood cells. You don't want red blood cells. The reason why? Because the iron content in the heme are toxic to the stem cells, right? They are free radical generators. That's why we are removing them. But I'm keeping the white blood cells. And I'm keeping the peripheral blood stem cells, which aren't contained inside among the white blood cells. So if I remove the white blood cells, the yellow buffy coat, I'm removing 0.6% of peripheral blood stem cells. That's not good. People say, well, white blood cells has a lot of proteases, may destroy the cartilage. According to the research that's been done, leukocyte-rich PRP, where they kept the white blood cells, and the pure PRP, they made a study, comparison study, they find out there's no change, right? Add to that, I want to be more cautious and be more, predictive. I'll go ahead and radiate the blood that I'm extracting, the 200, with infrared, red, blue light, to buffer the reduction in picotinamide oxide bioavailability and to modulate the white blood cells so they produce anti-inflammatory cytokines. It's called photomodulated leukocyte-rich PRP. Okay. So after you centrifuge, you get rid from the red blood cells, then you take the rest and you centrifuge it again, but 3,000 rounds per minute with 5 to 10 minutes. And what will happen? You deposit the stem cells, the PRP, the white blood cells in the bottom, and then you go ahead and remove the extra plasma, maybe half of it, or maybe more, depending on how much volume you want from the bottom. You can get 5 to 10 in each of this tube of leukocyte-rich PRP containing peripheral blood stem cells. And then you take them all and you inject them into the joints that you are treating, especially the musculoskeletal applications. And this, there's no really any manipulation here, right? All natural. And then I can go ahead and add hyaluronic acid, right? Just for providing the scaffold. I can go ahead and put topical nitro compounding containing polyphenols, thiols, nitric oxide. Why? Some ibuprofen if the patient has any irritation or inflammation. Because you don't want irritation and inflammation, right? It kills the stem cells. Remember when they say, don't put or seed those stem cells in the desert. You have to provide the right microenvironment for those seeds to grow, right? Same thing here in your joints. And so what is the microenvironments and how you can perfect it? Of course, topical nitro compounding will help. Light therapy sessions will help. Protease inhibitors, that's a good thing, will help. To making sure the environments around the stem cells are perfectly. And also you need to have that spark of the free radicals, the physiological one, to kick those stem cells and to stimulate them. So just dumping stem cells in the joint is not a good answer. We really need to add other things that help to perfect the microenvironment around the stem cells. Okay, prototherapy. Have you heard about prototherapy? Yeah, everybody here is doing it. And we're doing it with dextrose. But what is the mechanism of prototherapy? The mechanism of prototherapy, and that's very important. So in order for us to make the insurance pay for it, FDA, we have to know exactly what we're doing. A lot of doctors here, because of lack of understanding of the mechanism of prototherapy, they're injecting those sugar into inflamed joint. Don't do that, because those sugar are irritant and may aggravate the condition. So where we inject those PRP, they are like acupuncture. You inject them into the healthy tissue that surround the lesion. That's better, even subcutaneously if you want. So don't inject into the lesion, surround the lesion. Why? Because those irritant substance of dextrose will help to cause a spark of the free radical. I don't want to say inflammation, because a lot of doctors here will think, oh, inflammation means dysfunction, right? They connect that because that's what the signs of inflammation, right? That's what we taught in the medical school. Inflammation, dysfunction, redness, right? So I say spark of physiological free radicals that will stimulate the healthy tissue to produce antioxidant, anti-inflammatory growth factors that will help to heal the lesion. It's the same concept of acupuncture, right? Acupuncture, you irritate the tissues surrounding the lesion to generate a spark of the free radicals that stimulate the healthy tissue, not the pathological, the healthy tissue, to generate antioxidant growth factor and anti-inflammatory cytokines, and that will heal the lesion itself. Okay, so we use dextrose. I would like to change it to vitamin C high dose, right? But I hear that in the United States, it's not allowed to inject vitamin C into the joints. I don't know why. Doesn't make any sense, right? But if they don't allow it, then go ahead with vitamin B12 hydroxycobalamin. You can do that instead of vitamin C because it's irritant. And you can inject methylcobalamin into the joint itself, because methylcobalamin are a free radical scavenger, a powerful free radical scavenger. So you can inject the methylcobalamin into the joint, yes, and then hydroxycobalamin, use it in replacement of dextrose. That's possible. Answer. Okay, so I will do the motor neuron disease when I come back, because I have another 1 hour, 45 minutes. Do you have any questions? Because this will take another 15 minutes.
Yeah, no, it would be good to get back on track and then we can
Right.
pick it up on the other
So
side.
now I'm just giving you the basic of nitro medicine. Do you have any questions? Then we're going to talk about disease and how it's related to nitro medicine. Questions?
All right, we're gonna have a 20-minute break. Next door with vendors.
I have a question. Do you think we're developing immunotherapies? I'm being honest with you, you need you're still wired. I'm still wired, and they're hearing everything we're saying.
You don't want that.
I've had one a couple times.